Hyperbilirubinemia. Really bacha topic, literally, considering most of the defects are congenital. See, hyper means excess. Bilirubin is bilirubin and emia is blood. So the presence of excess bilirubin in blood is hyperbilirubinemia, which begs the question, what is the normal level of bilirubin in blood then? The normal serum total bilirubin is 0.3 to 1.2 milligram per deciliter as written in Robbins. And this total bilirubin contains two different types of bilirubin. Unconjugated bilirubin, which is also referred to as indirect bilirubin, and conjugated bilirubin, which is also referred to as direct bilirubin. And by now you must have already known that unconjugated bilirubin is lipid soluble, non-polar and toxic, while conjugated bilirubin is water soluble, polar and non-toxic. See, an increase in the level of bilirubin in blood is called hyperbilirubinemia. If this increase in bilirubin is that of unconjugated bilirubin, then it is unconjugated hyperbilirubinemia. If the increase in bilirubin is that of conjugated bilirubin, then that is conjugated hyperbilirubinemia. Simple. All right. Okay. Now the question is, what leads to increase in bilirubin in the body? And for that, you need to know the story of the metabolism of bilirubin. And fortunately, we have already learned that. We know the story of the metabolism of bilirubin. Now, in this story, there are specific areas or specific points, pinpoints, where pathological defects occur that lead to hyperbilirubinemia. So a short revision of the story of metabolism of bilirubin, but this time it will be stepwise, so that at these individual steps, then you can learn the defects, the pathological defects that occur leading to increase in the level of bilirubin in blood. Okay, so the story goes like this. The young RBC after 120 days becomes too old, and it inside the spleen of the body gets degraded or broken down into bilirubin, or specifically unconjugated bilirubin. So there is production. What? Production of unconjugated bilirubin. The unconjugated bilirubin then enters the systemic circulation. In the systemic circulation, it immediately binds with a plasma protein called albumin. So there is plasma protein binding, step 2. The plasma protein albumin carries the unconjugated bilirubin to the liver for the process of conjugation, where first the liver cell takes in the unconjugated bilirubin, which is referred to as uptake. After uptake, inside the liver cell, inside the hepatocyte, the process of conversion of unconjugated bilirubin into conjugated bilirubin takes place, which is referred to as conjugation. After conjugation, the conjugated bilirubin present within the liver can leak into the portal circulation via multi-drug resistant protein 3. But the leaked conjugated bilirubin is reuptaken, taken back. See, there was uptake here, then it leaked into the circulation, then it was reuptaken into the liver with the help of O1B1, 1B3 protein. So there is reuptake. Now, the conjugated bilirubin present within the liver, it is secreted into the biliary canaliculi. This is secretion. Secretion. The secretion takes place with the help of protein, multi-drug resistant protein 2. After secretion, it flows through the biliary system along with the bile to enter the second part of the duodenum. This is bile flow. So bile flow takes place. What is present in bile? In bile, you have the bile salt and acid. What makes bile salt and acid? That is also present, which is the cholesterol. And this conjugated bilirubin is present. After it flows through the biliary system, it enters the second part of the duodenum. Then within the gastrointestinal tract, the conjugated bilirubin is acted upon by the gut bacteria, which metabolizes it into urobilinogen. The urobilinogen is excreted out of the body, number one, through feces in the form of stercobilin, which provides feces its characteristic brown color, and number two, through urine in the form of urobilin, which provides urine its characteristic yellow color. So first, there was production of bilirubin, unconjugated bilirubin in the spleen. Then second, the unconjugated bilirubin bound with albumin plasma protein binding. Then third, the unconjugated bilirubin was taken into the hepatocyte uptake. Then fourth, the unconjugated bilirubin was converted to conjugated bilirubin by the process of conjugation. Then fifth, conjugated bilirubin leaked into the portal circulation. However, with the help of OAT1B1 and 1B3 protein, it was reuptaken. Then sixth, the conjugated bilirubin present within the liver is secreted into the bile canaliculi with the help of multi-drugger assistant protein 2. Then seventh, it flows along with the bile through the biliary system to the second part of the duodenum. And then finally, inside the duodenum, the conjugated bilirubin is metabolized by gut bacteria into urobilinogen, and the urobilinogen gets excreted out along with feces and urine. Good. You might be disappointed with the fact that I've been revising this topic so many times, the metabolism of bilirubin. But see, I'm gonna make hyperbilirubinemia so easy. Just see what chamatkar I'm gonna do. Boom, 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 and hyperbilirubinemia done. Yep, it's done. That's it. If you know the metabolism, you can pinpoint the defects, and then if you know where the defects are, you know what the topic is. That's it. So now all I'm gonna do is explain what I have done here. Hyperbilirubinemia. First, if there is increase in the production of bilirubin, which unconjugated bilirubin, beyond the capacity of the liver to conjugate it, obviously it is going to be very high in the blood, leading to unconjugated hyperbilirubinemia. An example, okay? So hypothetically, let's say hypothetically, in time 1 minute, 100 units of unconjugated bilirubin is produced by our spleen. In the same time, 1 minute, 100 units of unconjugated bilirubin is conjugated into 100 units of conjugated bilirubin. Okay, means all the unconjugated bilirubin produced by the spleen is conjugated by the liver in the same period of time. So is there any extra bilirubin left? No, it's not. Good. But let's say due to any pathological reason, now in the same time t equals to 1 minute, instead of 100 bilirubin being produced, 1000 bilirubin, unconjugated bilirubin, gets produced in the spleen. But in the same time t equals to 1 minute, the capacity of the liver is still the same. It still conjugates 100 unconjugated bilirubin to 100 conjugated bilirubin. That means how many extra unconjugated bilirubin remains in the blood? Subtraction, brother. 1000 minus 100, 900. There is still extra 900 unconjugated bilirubin in your circulation. Too much unconjugated bilirubin, unconjugated hyperbilirubinemia. Point 2. Let's say the production is normal. Okay, 100 UB is being produced. Now this 100 unconjugated bilirubin, it attaches with albumin in the systemic circulation. Let's say this plasma protein binding does not take place. Then what? Then what will happen? The unconjugated bilirubin is transported to the liver by albumin via plasma protein binding. If plasma protein binding will not take place, unconjugated bilirubin, which is free now, not bound to any protein, will not reach the liver. If it will not reach the liver, conjugation will not take place. Why is conjugation required? I've already taught you, conjugation is required to get conjugated bilirubin. Why? To excrete it out, to excrete it out of the body. So if UB is not transported by the albumin, since there is no plasma protein binding, conjugation will not take place and subsequently excretion will also not take place. Unconjugated bilirubin will get accumulated, free unconjugated bilirubin will get accumulated in the blood, also leading to hyperbilirubinemia with unconjugated hyperbilirubinemia. Number 3, let's say production is also normal. Plasma protein binding is also normal. So the albumin takes all the 100 UB to the liver. But the problem is here in the liver. The unconjugated bilirubin uptake does not take place. There is impairment in the uptake. As a result, same thing. Conjugation will not take place. Excretion will not take place. Unconjugated bilirubin will get accumulated in the blood, leading to unconjugated hyperbilirubinemia. Number 4, let's say production is normal, plasma protein binding is normal, uptake is normal, but now in the hepatocyte, the process of conjugation is impaired. As a result, unconjugated bilirubin is not converted to conjugated bilirubin. Then what? Same thing. Excretion will not take place. Unconjugated bilirubin will get accumulated in the liver cell, and then it will be pushed back into the circulation, leading to unconjugated hyperbilirubinemia. Till this point, these defects at number 1, 2, 3, and 4 led to increment in the level of unconjugated bilirubin in blood, leading to unconjugated hyperbilirubinemia. Distal to this, or after this, all the defects is going to lead to accumulation of conjugated bilirubin in the blood, leading to conjugated hyperbilirubinemia. Let's see how. Okay, so till here everything's fine. Conjugated bilirubin is formed. What happens to conjugated bilirubin? It leaks into the portal circulation. But then this leaked conjugated bilirubin is reuptaken with the help of OAT1B1, 1B3 transporter. Let's say this reuptake does not take place. So now all the conjugated bilirubin will get accumulated in the portal circulation, and eventually from there it will enter the systemic circulation, and now you have increased level of conjugated bilirubin, conjugated hyperbilirubinemia. Okay, let's say reuptake is fine. Okay, conjugated bilirubin is now secreted into the biliary canaliculi, but now secretion does not take place. See, secretion does not take place. Accumulation of conjugated bilirubin, and then it is pushed back into the circulation again. Let's say secretion is fine also. Now conjugated bilirubin is secreted into the biliary canaliculi. It has to travel through the biliary duct system. But then there is problem with the bile flow. What will happen? Conjugated bilirubin will get accumulated. It will get pushed back. It will be pushed back. Accumulation, pushed back into the circulation. Rise in conjugated bilirubin in circulation. Conjugated hyperbilirubinemia again. See, at each point of the metabolism, I showed you the defect leading to increase in level of bilirubin in the blood, where before this point at step 1, 2, 3, and 4, the defects led to unconjugated hyperbilirubinemia, and distal to that point at step 5, 6, and 7, it led to conjugated hyperbilirubinemia. So one last revision. There is increase in the production of unconjugated bilirubin beyond the conjugating power of liver, increase in bilirubin. Number 2, there is decrease in the binding of unconjugated bilirubin with albumin. So there is too much free unconjugated bilirubin in the blood, increment. Number 3, the unconjugated bilirubin that reaches the liver does not enter the cell of the liver. So conjugation does not take place. So there is increase in unconjugated bilirubin in blood. Number 4, within the liver, the process of conjugation does not take place. Increase in unconjugated bilirubin. Till here, unconjugated hyperbilirubinemia. After that, the conjugated bilirubin leaks into the portal circulation, but it is supposed to be reuptaken into the liver. Reuptake does not take place. Too much conjugated bilirubin in circulation. The conjugated bilirubin is secreted into the biliary canaliculi. Secretion does not take place. Too much conjugated bilirubin in the liver, which gets pushed back to the circulation. Let's say secretion takes place, after that it has to pass through the bile system, but then there is some blockage, there is decrease in the bile flow. All the conjugated bilirubin gets accumulated in the biliary duct system, pushed back into the liver and back into circulation. That's it. Now what you need to know. Now what you need to know is that for individual reasons, what are the pathologies backing it off? That is, okay, there is increase in production of unconjugated bilirubin leading to unconjugated hyperbilirubinemia. But what causes the increase in production? What causes the decrease in plasma protein binding? What causes the decrease in uptake? What causes decrease in conjugation? What causes the decrease in reuptake? What causes the decrease in secretion? What causes the decrease in bile flow? Let's see. Starting off with unconjugated hyperbilirubinemia. Again, before this, all of it, 4 of them, unconjugated hyperbilirubinemia. Starting off with production. First, increase in production. What causes increased production of bilirubin? Hemolytic anemia. When there is hemolytic anemia, there is excess hemolysis. That is excess breakdown of RBC, excess degradation of hemoglobin, leading to excess production of bilirubin. Simple. Excess production of unconjugated bilirubin in the spleen. Simple. Second, hemolytic anemia. Then resorption of internal hemorrhage. Whenever there is internal hemorrhage or internal bleeding, what happens? There is accumulation of RBCs leading to formation of hematoma. All the RBCs present in the hematoma gets broken down, dies, gets eaten up by macrophage and converted into bilirubin. Which bilirubin? Unconjugated bilirubin. So, unconjugated hyperbilirubinemia. Third, impaired erythropoiesis. Impaired erythropoiesis or defect in erythropoiesis. Let's take an example of pernicious anemia. What happens in pernicious anemia? In pernicious anemia, there is increase in the rate of production of erythrocytes in bone marrow, red bone marrow, or there is accelerated erythropoiesis. During accelerated erythropoiesis, along with increase in the production of RBCs, there is also increase in the destruction of immature RBCs. So new RBCs are being made fast, but at the same time, immature RBCs are being killed faster as well. So the macrophage, they will eat up the immature RBCs, leading to increase in the production of unconjugated bilirubin. See, let's take an analogy, all right? You are given bunch of resources. You are given glue, paper, paintbrush, paint, some stickers to make a collage. You use those resources to make the collage. But then when you make the collage, you cut a piece of paper, throw out a part of it. You use glue, not all of it gets used, it gets thrown as well. Paint as well, you use some of it, you throw some of it. Stickers as well, you use some of it, you throw some of it. So the end collage that you get is your RBC, and the resources that you have thrown are the hemoglobin that got wasted away during the production of the new RBC. That is why when more RBC is being made, more hemoglobin is getting wasted, and these hemoglobin are being eaten up by the macrophage, being converted into bilirubin. Accelerated erythropoiesis, but subsequently increase in the destruction of immature RBCs as well, and increase in the production of unconjugated bilirubin as well. Okay. Second, decrease in plasma protein binding. Do you remember your pharmacology? Something called sulfonamides. See, sulfonamides, they have a higher affinity to albumin. That is why they displace the unconjugated bilirubin and itself attaches with, they displace the unconjugated bilirubin and itself attaches with albumin. So now what happens? There is free unconjugated bilirubin in the blood, free unconjugated bilirubin, leading to increase in the level, unconjugated hyperbilirubinemia. What if this condition is present in a neonate? Okay, a new terminology for you guys. Kernicterus. Ever heard of it? Side effect of, you might have read that the adverse effect of sulfonamide is kernicterus in neonate. What is that? See, let's say there is a newborn and this newborn has an infection. So the doctor prescribes sulfonamide to the newborn. What will sulfonamide do? The sulfonamide will compete with unconjugated bilirubin. Since it has a higher affinity towards albumin, it will displace the unconjugated bilirubin and itself go and sit there. So there is increase in the level of unconjugated bilirubin in blood, free unconjugated bilirubin in blood. And I have taught you that unconjugated bilirubin, since it is lipid soluble, it is highly permeable. Okay, this is one part of the story. Second part, in a newborn child, the blood-brain barrier is not well developed. It is poorly developed. So now this lipid soluble unconjugated bilirubin can easily permeate through the blood-brain barrier and enter the central nervous system. Then this unconjugated bilirubin will go and deposit in the basal ganglia and other nuclei of the central nervous system, leading to brain damage, neurological damage. This is kernicterus. Once more. What will sulfonamide do? It will displace unconjugated bilirubin. So now there is increase in the level of free unconjugated bilirubin. This will cross the poor blood-brain barrier present in the neonate. And then it will go and accumulate, or it will go and deposit in basal ganglia of central nervous system and other nuclei. This leads to brain damage and neurological damage. That is kernicterus. Good. All of this is occurring in a neonate. Remember, because they have poorly developed blood-brain barrier. That's why the free unconjugated bilirubin can easily permeate through it. All right. Third, reduction in uptake. Another pharmacology, rifampicin drug. Heard of it? Anti-TB drug. Okay. Rifampicin, it inhibits uptake. As a result, unconjugated bilirubin is not taken up by the hepatocyte. That is why mild hyperbilirubinemia is seen in TB patients going through anti-TB therapy or DOTS. Then decrease in conjugation. As soon as I say decrease in conjugation, first thing is physiological jaundice of newborn, and as well as breast milk jaundice. So this is quite an interesting topic. That is why I'll take this topic separately. Okay, so I'll explain this topic. I'm not leaving it behind, but then separately at the end of the lecture, okay, or in a different lecture. Conjugation. Okay. See, conjugation. Decrease in conjugation. Why would a decrease in conjugation take place? A very important reason for decrease in conjugation is decrease in activity of the enzyme responsible for conjugation. See, what is happening in the conjugation? Unconjugated bilirubin is converted to conjugated bilirubin by the conjugation of glucuronic acid to unconjugated bilirubin. And for this, the help of enzyme glucuronyl transferase is required. The help of GT is required. So GT is responsible for conjugation in liver. Let's say this GT is either impaired, that is, it does not function properly, or it is less in amount, then conjugation will not take place. Simple. So now you need to know different conditions where the function of GT is impaired or the GT itself is less or absent. As a result, conjugation does not take place. Let's see those conditions. Okay. First, there is neonatal deficiency of GT. Second, there is mild deficiency. Okay, I'm not going to use red only for the conditions. Neonatal deficiency of GT, mild deficiency of GT, then partial deficiency of GT, and complete deficiency of GT. Neonatal deficiency of glucuronosyltransferase leads to physiological, I'm going to write in short, physiological jaundice of newborn. This right here, okay? Physiological jaundice of newborn. That is, there is deficiency of glucuronosyltransferase in a newborn. The reason it is called physiological is because it is normally present in all newborn. In all newborn, normally there is less amount of glucuronosyltransferase in their body, or deficiency of glucuronosyltransferase in their body. The reason being, the gene that is responsible, the expression of gene that leads to the formation of this protein, glucuronosyltransferase, is still not, the gene is still not expressed in the chromosome yet. Got it? See, gene is responsible for the production of protein. The gene, there has to be a gene that is responsible for the production of glucuronosyltransferase as well. In a newborn, this gene is not yet expressed in the chromosome. That is why they have deficiency of GT. Since there is deficiency of GT, conjugation does not take place in the newborn. That is why mild hyperbilirubinemia is seen in newborn for at least 1 week. Okay. That is why for 1 week, for around 1 week, mild hyperbilirubinemia is seen, and around after 3 to 4 months, everything becomes normal because the gene is now well expressed, the same as that in adult. How much the gene is to be expressed in adult is now expressed within 3 to 4 months. Mild deficiency, this is seen in Gilbert syndrome. I missed out one thing, right? So I said here in the third step of unconjugated hyperbilirubinemia, decrease in uptake. So it's not just rifampicin that brings decrease in uptake, but also Gilbert syndrome. Gilbert syndrome also brings sometimes decrease in uptake. But then the main concern with Gilbert syndrome is the mild deficiency of glucuronosyltransferase. Partial deficiency, that's Crigler-Najjar syndrome type 2, and complete deficiency, that is Crigler-Najjar syndrome type 1. Okay, mild deficiency. Since in Gilbert syndrome, there is only mild deficiency, it is mostly asymptomatic. But manifestation of symptom takes, right? Manifestation of symptoms takes in special condition like stress, fever, and pregnancy. As for type 2 Crigler-Najjar syndrome, there is partial deficiency, right? In newborn, since it is a congenital defect, in newborn, there is partial deficiency of glucuronosyltransferase, for which you use phenobarbital as drug therapy. What phenobarbital does is that it increases the production of, it forcefully increases the production of GT. It forcefully triggers that gene to produce more glucuronosyltransferase. As for type 1, there is complete deficiency. There is no GT at all in the body. That means conjugation in this baby does not take place. There is no conjugation at all in the baby. There is a huge increase or accumulation of unconjugated bilirubin in the blood. That is why this is 100% fatal. The baby dies. Okay. So that was all for unconjugated hyperbilirubinemia. First, increase in the production of unconjugated bilirubin itself by hemolytic anemia or resorption of hematoma or impaired erythropoiesis like seen in pernicious anemia. Number 2, decrease in plasma protein binding due to sulfonamide poisoning. 3, decrease in uptake of unconjugated bilirubin by the liver due to rifampicin or Gilbert syndrome. 4, decrease in conjugation as seen in physiological jaundice of newborn and breast milk jaundice. But most importantly, 3 congenital abnormalities: Gilbert syndrome, Crigler-Najjar syndrome type 1 and Crigler-Najjar syndrome type 2. In Gilbert syndrome, there is mild deficiency of GT. In Crigler-Najjar syndrome type 1, there is partial deficiency of GT. And in Crigler-Najjar syndrome type 2, there is complete deficiency of GT. In Gilbert syndrome, due to mild deficiency, it is asymptomatic, but symptoms are manifested during special conditions like stress, fever, and pregnancy. Crigler-Najjar syndrome, there is partial deficiency in the baby of GT, so phenobarbital is given as drug therapy. As for permanent solution, that is liver transplant. In Crigler-Najjar syndrome type 1, there is complete deficiency, so there is absolutely no GT, no conjugation taking place, so it is 100% fatal. Okay. Second, conjugated hyperbilirubinemia. Everything distal to this leads to conjugated hyperbilirubinemia. Starting off with decrease in reuptake. Decrease in reuptake takes place due to OAT1B1 / OAT1B3 mutation, which is seen in Rotor syndrome. Second, decrease in secretion into biliary canaliculi. Secretion takes place by which protein? Multi-drug resistant protein 2. So if mutation takes place there, obviously the secretion is not going to take place, and it is seen in Dubin-Johnson syndrome. Next, decrease in bile flow. So first was decrease in reuptake. For that, if mutation takes place in OAT1B1, 1B3, there is decrease in reuptake. That is, these proteins, they are no longer functional, so reuptake does not take place, and that is seen in Rotor syndrome. Second was decrease in secretion. So decrease in secretion takes place when the protein responsible for secretion is mutated. There is mutation in multi-drug resistant protein 2, which is seen in Dubin-Johnson syndrome. Third is decrease in bile flow. Decrease in bile flow can take place, number 1, when there is obstruction in the flow, right? Obstruction in the flow, or if there is inflammation. So 2 conditions: cholestasis and cholangitis. Since both of them are really big topics, I'm gonna have lectures differently for these 2 topics as well. Another question: what is the main difference between Rotor syndrome and Dubin-Johnson syndrome? The difference is, in Dubin-Johnson syndrome, the liver, it is black or highly pigmented, liver. So when you do the biopsy of the liver grossly, it is black pigmented. The reason being, in Dubin-Johnson syndrome, there is accumulation of catecholamine metabolite, right? Epinephrine metabolite. After the metabolism of catecholamine, what metabolite remains, it goes and deposits in the liver in Dubin-Johnson syndrome, leading to blackening of the liver, because that metabolite itself gives that black pigmentation. Good. All right. Okay, we talked about unconjugated hyperbilirubinemia. We talked about conjugated hyperbilirubinemia. But there's a very important, shall I say, the most common pathological defect that actually causes both. That causes increase in unconjugated bilirubin as well as an increase in conjugated bilirubin. So if you use your tiny brain, you can guess that such a pathology has to occur at intersection between the both, right? The yellow and the white intersection between the both. So somewhere around here that pathology has to occur. So let's see that pathology. Let's say the inflammation of the hepatocyte cell right here takes place. Due to inflammation, there is loss of function of the cell. As a result, conjugation does not take place. As a result, there is accumulation of unconjugated bilirubin in the blood. Good. Due to inflammation, there is increment in the size of the hepatocyte. Okay. Due to increment in the size of the hepatocyte, what happens? It presses upon the outflow. It presses upon the various outflow. The cells, they press against one another and they also press upon the biliary canaliculi. So there is obstruction in biliary canaliculi. As a result, even after conjugation, the conjugated bilirubin, it does not have any outflow to go through. It can't go out of the cell because it is constricted within, it is trapped within the cell. So there is increase in conjugated bilirubin, accumulation of conjugated bilirubin, and it is pushed back into the circulation. Again, there is inflammation of the hepatocyte. Due to inflammation of the hepatocyte, there is loss of function of the cell. Due to loss of function of the cell, conjugation does not take place. Since conjugation does not take place, there is accumulation of unconjugated bilirubin in the cell. This accumulated unconjugated bilirubin in the cell gets pushed back into the circulation, leading to increment in the level of unconjugated bilirubin in the blood and unconjugated hyperbilirubinemia. Done. Since there is inflammation, there is increment in the size of the cell. These cells, they press against one another and they also press the biliary canaliculi, leading to obstruction in the biliary canaliculi. As a result, the conjugated bilirubin is unable to be excreted out of the cell. So it gets accumulated in the cell, and the accumulated conjugated bilirubin gets pushed into the circulation as well. As a result, there is increase in the level of conjugated bilirubin or conjugated hyperbilirubinemia. There is both, brother, there is both. And the inflammation of hepatocyte is seen when? It is seen in hepatitis. But then the better thing to say is hepatocellular defect. In hepatocellular defect or injury like hepatitis and cirrhosis. In hepatitis, cirrhosis, any sort of hepatocellular defect like chronic liver disease, right? There is increment of both conjugated and unconjugated bilirubin. Okay, so every point that I have mentioned has been mentioned in this table, and this table is from Robbins. So every point I have said is indeed from Robbins. There are few topics remaining for which I have a different lecture. One is the physiological jaundice of newborn and breast milk jaundice, and then a short video on just the congenital hyperbilirubinemia.